I'm afraid that my talk will be a little bit more technical than Natasha's really great advocative talk about breastfeeding. I did change the title of my talk a little bit, so it will be an update on the use of antiretrovirals in pregnancy and breastfeeding, and it will be a pharmacology perspective. These are my disclosures, and this is the content of my talk. I'm going to say something about pharmacokinetics and pharmacology in pregnancy as an introduction, because I've been to this workshop before, and I regret that there was not a lot of pharmacology or pharmacokinetics in the workshop. So I think not everybody is very aware of how it all works. I'll give a summary of the pregnancy effect on pharmacokinetics of antiretrovirals, of placental transfer, and also of breast milk transfer, which is a nice bridge between the two talks in front of after me. So this is probably what we all know, is pregnant and breastfeeding women or people are generally excluded from clinical trials during the development phase of the drugs. And that leads to knowledge gaps when the drug comes to the market. So what don't we know? We don't know the pharmacokinetic changes of a drug. I will go into that later. Does the drug cross the placenta? We don't know that. Is it safe for the fetus? And does it transfer into breast milk? So do we have exposure of the baby during breastfeeding? This slide I always use and update during the years. It was published in CID a couple of years ago. But this shows the median knowledge gap of when a drug comes to the market, an antiretroviral, and when we have the first pharmacokinetic information in pregnancy available. And that's only pharmacokinetics, so safety information is usually a lot later even, but that knowledge gap is 5.5 years, and we would like to shorten that period. So let's go into pharmacokinetics. What is pharmacokinetics? Pharmacokinetics is what the body does to the drug. So we study that in the time course of the drug coming into the body, like after oral ingestion. This is a typical pharmacokinetic curve. After oral ingestion, you see the time after dosing on the x-axis and the concentration of the drug on the y-axis. So it goes up and down, and we know what the therapeutic concentration should be. So we don't want it to be too low, because then it's subtherapeutic. We don't want it to be too high, because then it might be toxic. But what happens in pregnancy? A lot of things. If you have been pregnant, you probably know you'll get bigger and things, but that's not the only thing that changes. So there's a bigger volume to distribute the drug over. You can imagine that. So that's one of the distribution things that changes for a drug. But also absorption changes. Well, you can imagine nausea may influence that, but also pH changes in your stomach. Then metabolism, in the liver metabolizes medicines, and due to hormonal changes, also this metabolism changes. So some drugs are being broken down quicker and other ones slower. And then we've got elimination, for example, through the kidneys. So the renal blood flow is higher, and also the GFR is higher during pregnancy. So what we mostly see is an overall effect is lower exposure to a drug during pregnancy. But it can also be higher when the enzymes are inhibited that break down the drug. But overall, the effect is lower concentrations. But the question is, should the dose be adapted in pregnancy or not? I will go into this question for the currently preferred antiretrovirals in pregnancy, especially for the naive patients. So this is what is currently in the DHHS guidelines for the NRTIs, abacavir 3TC, TAF FTC or 3TC, TDF FTC or TDF 3TC. For integrase inhibitors, dolutegravir is the preferred compound. And that has a star, so we don't see these neural tube defects anymore. So because of the larger studies that have been done now, the CEPAMO study and also Eswatini, we think there's no increased risk anymore. And for the protease inhibitors, darunavir/ritonavir is the preferred compound, but should we give it once daily or twice daily? That's the question. So how do we study pharmacokinetics in pregnancy? Well, there are one big network, which is the IMPACT network, who's doing that sort of studies, and the PANDA network, which is my European smaller sister. It's an opportunistic design study, so women already use the antiretrovirals, they become pregnant, and then we ask them to come to the clinic in the second and third trimester during pregnancy, and we collect this pharmacokinetic curve, as I showed you before. We also ask them to come back after delivery in their postpartum phase, and we start at 4 weeks after delivery, but maybe 6 weeks is better, because that's the control curve. At that moment we say, okay, there's the influences of pregnancy have gone. You can imagine that maybe 6 weeks after pregnancy you think, oh, I'm not back to my normal weight, but most of the pharmacokinetic changes I showed you are gone by then. And then during delivery, we also try to get a cord blood sample. So that's one of the examples how we can study pharmacokinetics, effect of pregnancy on pharmacokinetics of drugs. But there's also another option. So we have physiologically based pharmacokinetic modeling, which means that we've got a computer model of the body, and all these changes I showed you, induced enzymes during pregnancy, are all in that system. Also the placenta is in the system and the fetus is in the system. So we can predict, when we've got the chemical data of a drug, you put that into that computer model and you'll get a prediction of what will happen to the concentrations in pregnancy, and also a prediction of what the fetal exposure during pregnancy will be. And these models are being are validated now, and they are getting better over time. So how does it look, these pharmacokinetic changes in real world? So I've summarized on this slide, I've summarized what is happening in pregnancy, and I will explain this one a bit better because we'll see a few of them. So what we do is we have the area under the curve, a pharmacokinetic parameter in pregnancy, divided by the control curve. So then you see the pregnancy effect. And this curve, this figure, shows the geometric mean ratio with a confidence interval. It means that when you see the lines, the dots and the lines to the left of 1, it means that that there is lower exposure in pregnancy. So you see that for most NRTIs we have lower exposure in pregnancy, but the fact that these bars are blue means that it's not clinically relevant. So, and for abacavir you even see that there's really no pregnancy effect to be detected. Then let's go into the integrase inhibitors and protease inhibitors for dolutegravir and darunavir, for example, in pregnancy. So I've summarized the 3 dolutegravir studies, and there you can see that it's a little bit low, that it's lower in pregnancy, but also crossing this line of 1, so it's not relevant. Darunavir is a little bit more tricky, and especially when you combine darunavir with cobicistat, you see that it's red and that it is clinically relevant, these decreases in pregnancy. But does it matter? For most antiretrovirals, no, it doesn't really matter. But for some it does. And especially for cobicistat-boosted regimens, it's really not recommended to use these in pregnancy because of the lower concentrations. But then we've got a problem for darunavir because the guidelines and the labels, well, the guidelines are quite consistent, but the label is different between FDA and EMA. So the Europeans think that we don't need a dose adaptation of darunavir in pregnancy. You can give the once daily darunavir dose. But in the FDA, based on the same data, decided that you should take 600 milligrams with 100 milligrams ritonavir twice daily. And well, that makes life very complicated, and we don't have the answer for it. But I think that especially when somebody is suppressed on darunavir once daily, becomes pregnant, it wouldn't be a problem. Starting somebody on darunavir once daily in pregnancy, that's something we have to think about, and we are researching that in terms of efficacy now. Then the newer drugs, bictegravir. We've got 3 studies up to now reporting bictegravir concentrations in pregnancy, and you can see it's quite a lot lower in pregnancy than postpartum. But still, we don't think that there is a relevant effect, because the unbound concentrations are quite similar, less affected, and there is a target concentration, so the effective concentration is still there. But it's really lower, so we have to take a little bit of concern. We have to be aware of that, I think. Then cabotegravir rilpivirine in pregnancy. We don't have data on ongoing injections during pregnancy, but we do know that the half-life, the terminal half-life in pregnancy is not different from the half-life we see in non-pregnant people. And the only thing, there has been a PBPK model recently suggesting that rilpivirine levels when you continue the injections will be quite a lot lower during pregnancy, and maybe even below, for quite a lot of patients, below the target. And we are waiting for the real-world data to confirm that or not confirm that. So hopefully that will be solved soon, or we will get more information on that. Then doravirine, we don't have clinical data either. My PhD student Vera Buckham's published a PBPK model as well, and she also predicted quite a pregnancy effect, like 55% lower exposure in pregnancy, and that also has to be confirmed in real life. Lenacapavir islatravir, no data yet, no models either, so we don't know yet what is happening PK-wise, but the good news is that for both compounds, people who become pregnant during the clinical trial phase can stay on the study drug after informed consent, and for a pharmacokinetic curve will be taken. So we'll have data sooner, hopefully. Then, very quickly about placental transfer of preferred antiretrovirals. So here you also see a similar graph. One means that the cord blood concentration is as high as the maternal blood concentration, so this compound passes the placenta very well. For all the NRTIs, you can see that they do pass the placenta very well. Then, let's look at the integrase inhibitors, dolutegravir, and I put bictegravir in as well. They cross the placenta very well, so they are really available in the fetus. Darunavir, almost all protease inhibitors are hardly crossing the placenta. They will be in the fetus, but a lot less. And what is also important for dolutegravir that goes, but for bictegravir, the half-life in neonates is a lot longer when you would compare it to adults. So the baby is exposed through the mother, and the bictegravir will be in the blood of the baby with a half-life of 43 hours. Anyway, and then I want to go into the breastfeeding. Well, we know that the DHHS guidelines have been changed now, that both options should be supported, breastfeeding and also formula feeding. So we've been talking about the chance of HIV transmission, but I want to show you something about the breast milk the concentrations of antiretrovirals. And here you see this same graph I showed for the pharmacokinetics in pregnancy, but then for breast milk transfer of antiretrovirals, the gap is even longer than for the pharmacokinetics in pregnancy. And what is this breast milk transfer? Here, maybe it's a little bit a complicated graph, but you see the classes of the antiretrovirals, and it's Caroline's study I'm referring to here. I made a nice graph of it. So you can see here the integrase inhibitors, and you see that bictegravir and dolutegravir do not cross into breast milk very well. And then you see the raltegravir, for example, for the integrase inhibitors, quite crosses into the breast milk with a factor 1:1. NNRTIs, they cross into breast milk, and then NRTIs also, and protease inhibitors not that. And the protease inhibitor, we know things about darunavir, not very well. But what does that mean, this breast milk plasma concentration? We can calculate a relative infant dose from these breast milk plasma concentrations. And that means that we are calculating the percentage of the maternal dose that gets into the infant during breastfeeding. This is it is a prediction, but you can calculate it from these figures. And it's generally considered that less than 10% of that dose, when it's getting into the child, is safe. And for the antiretrovirals we know things about, so all these compounds, it's less than 10%, it's even less than 6% or 5%. So in terms of the breast milk exposure to antiretrovirals, it's safe, but we have very low concentrations in the child. When a transmission of HIV occurs, it could be dangerous because of resistance development. So that's the downside of having these low concentrations. And I don't think that through breast milk you will get concentrations that are high enough to protect the child from being infected. Then I want to advocate a little bit for our PANA-B study. So we're doing the same sort of TDM study Caroline has been doing. But we also do a PK study in which we ask a healthy woman who is breastfeeding to stop breastfeeding and ingest one dose of an antiretroviral, and then we'll measure these pharmacokinetic curves in breast milk and in plasma. I thought it was a really good idea to get earlier information, but recruitment is not very easy to find volunteers who want to do that. We already have one, but we are going to get more hopefully in the future. And we are also complementing this with this PBPK modeling now. So the take-home messages from my talk is that during pregnancy, clinically relevant pharmacokinetic changes can be expected. Drug labels are not always consistent regarding dosing advice in pregnancy, so you still have to think, and you're on your own as a doctor. Most drugs cross the placenta, integrase inhibitors more than NNRTIs and NRTIs, and dose more than PIs. Lactation studies lag behind even further than pregnancy PK studies. Not only the milk plasma ratio is important, but also especially this relative infant dose. And for most antiretrovirals up till now, the relative infant dose is less than 10%, so it's considered safe, but be aware of when the child has an infection to look at the resistance. And this in silico modeling can help to predict PK changes in pregnancy, fetal exposure, infant exposure through breastfeeding. And this is also bit of advocacy to the call to action we have written with a few people here in the room as well, isn't it? Angelina, no, you're not on it. But you were in my group though, yeah. So accelerating the study of new drugs for HIV in pregnant and breastfeeding women. But this new one by the national academies, I really advise everybody to go to their website and download this 400 pages document, but it's but especially look at the recommendations because it's really interesting what they are proposing. So in advancing clinical research of pregnant and lactating population in general, so not only HIV but in general. It has been released last Wednesday, I think. So the real take-home message is protect pregnant women through research, not from research, and not only for COVID as on this little graph. And a little quote from one of my colleagues, that pregnant and lactating women are medical pharmacologically complex populations, but that does not mean that they don't have the right on well-investigated drugs. These are my acknowledgements, and that's it. We'll have questions later.